Yeah, welcome everybody. Welcome back. Please take your seats. So we are now in session 4, regulation and country priorities. And we have 3 exciting talks. Let's start right away, not lose time. So the first talk is by Shashank Ray of the United Nations International Computing Center. And please.
Good afternoon, everyone. Thank you. I'm sort of quite a recent joiner into this panel. Samir Pujari, who is co-chairing it, got me in about a couple of weeks back. But still, I'd like to sort of claim that this was all well orchestrated, given what the last panel was discussing. And the last single word that was left as the problem statement was trust. So let me just make sure this is working for me. Excellent. So when we talk about taking artificial intelligence and sort of using it across countries, across international borders, my view is digital trust becomes very, very important, as it was highlighted in the discussion of the previous panel. So what I'd like to do is, one, we are not as famous as the WHO or the ITU or for that matter EPFL. A very quick introduction as to what UNICC is, the United Nations International Computing Center, what we do, and then sort of feed or provide some thoughts around digital trust as a more means for active discussion with the panel. So as far as ICC is concerned, we were sort of established about 45 years back. It was a General Assembly resolution of the United Nations. Back then it was set up to run mainframe for a few UN agencies. Obviously the era of the mainframe is over, or at least that's what we like to feel. We still are running 2 mainframe computers, talking about AI. But no, we do more than AI now. We are working on things like blockchain. We are working on machine learning solutions for different agencies, robotic process automation, and various other pieces. We are about 420 odd UN staff and consultants. And I think I made this point when we were talking about legal liability, etc. We do operate still on-prem stuff, which is all covered under UN PNI, privileges and immunities, which means that this is a bit above and beyond the national regulations and national laws. That's our global presence. I'm sure you'll find this on our website as well. So let's try and slightly dissect digital trust. And hopefully this is not controversial, because at least in my very humble opinion and some of the studies that I have highlighted over here, digital trust, in my view, goes a bit above and beyond the trust and the security we were talking in the previous sessions. And I'm sure these were the discussions in the morning as well. So, I mean, feel free to refer to these, and I'm sure, you know, there are better scholars in the room than me who will sort of find out, go to Google Scholar and you can look up on different articles on digital trust. But I think when we talk about digital trust, it combines 2 different factors. So there is, on what I would call the left-hand side of this brain, is it my left? It is my right. So on the right side end of this brain is the computational trust. I think that's what we've been discussing in the previous panel and probably in the morning, which is about what are the algorithms doing, how are they doing it, can they be tampered to reach those conclusions. There's another part to digital trust, a more softer part, and being a part of the UN ecosystem, we see this on day in and day out basis. And slightly, a good friend from WHO had raised this question about how can developing countries sort of catch up with these complex issues. And I want to slightly touch upon that, which is the operational trust. Who is handling my information beyond the system? Who are the human operators? And the issues when they start to intersect with privacy concerns. So I would sort of go into 2 examples to show how it's not just a question of machine and information security or, you know, encryption, but where actually when you're working in international borders, digital trust becomes important, and sort of the role or some of the use cases where we have played a role. So there is a program within WHO, incidentally, which is called the Relational Sequence TB Data Platform. What this program is, and I do apologize if I pronounce any of this wrong, I'm not a doctor. They're looking at a catalog of genotypic and phenotypic metadata to analyze drug susceptibility testing of Mycobacterium tuberculosis. I think I got this right with the nods in the audience. Thank you very much for the confirmation. But long story short, they're picking up genomics data from multiple countries. The countries are submitting the data, they're analyzing the genomic sequence to find out how the drugs are becoming, what I'm looking for here is immune, how the bacteria is becoming immune to various drugs. Now, the whole reason that WHO is running this program is because the countries are not comfortable in giving their genomic data to any non-UN entity over here, any national government, any NGO, and thus the digital trust over here is not just about encryption. It's not just about, any other technology piece, but the fact there's an institution in which more of the trust lies. And therefore, the whole system is running under WHO umbrella. So this is sort of a food for thought that when we talk about in this panel about supporting global public health, this is something that needs to be considered. Another example I would like to present is, it's a not health-related example, but sort of similarly related when we talk about building capacities within countries. We have been working with another UN organization called FAO, the Food and Agriculture Organization of the UN, which is based out of Rome. They run an International Plant Protection Convention. And when we were talking about developing capabilities in developing nations or least developed nations, they set up a framework, FAO set up a framework by which they brought in digital processes and they brought in the associated digital technology to these nations to actually evolve and develop. Again, as I said, these are just food for thoughts for this panel to sort of consider on how can a body like WHO or ITU bring forward AI into developing nations, into countries beyond the ones who already have this technology. That's pretty much it. I think the questions are more or less for the end. So I thank you all. This was short and sweet. Thank you.
So very direct question. Could you run benchmarks for us? Yeah. Oh, wow. We resolved this part, Marcel. Excellent. So our next speakers are Lina Sankla and Kashef Sankla, Solutions for Health. I think Lina will be giving the talk.
Good afternoon, everyone. Thank you very much to the organizers for inviting us here today to present and to actually share our experience around lifestyle services and how digital health, or M-Health, as Samir always says, right, makes an impact on behavior change on a large-scale population. Okay, so Solutions for Health. Who are we? What do we do? So we're a national organization across in the UK. We deliver healthcare services. So we have 3 divisions. We have a healthcare division, we have an information systems division, and we have an AI and innovation division. So what I really love about that is because you've got IT, you've got innovation and AI, and you've got healthcare. All 3 major sectors of public health in one house. And I think that's what I'm really passionate about. My background, I'm a consultant in public health, and I'm also the director of public health for Solutions for Health. So I am not an IT person. So when I work with our team, I actually give our AI and IT team the most difficult case scenarios, and I ask them to go and resolve it for us. In short, we deliver clinical and non-clinical services. We deliver across in the UK. We're commissioned by local authorities, which are the local councils who are responsible for their population, which means it could be anything from smoking to weight management to falls prevention for the elderly, 0 to 19, which is health visitor and school nurses, and equally sexual health services. So it's a kind of a broad spectrum. I now say we deliver 0 to 100 because people are living longer thanks to all the research and the science that we have all contributed to. Our journey actually started from stop smoking services. So the reason I'm taking smoking today as a storyboard is because I would like to kind of highlight why we did this, because it's the most preventable cause of death. We all know. And obviously, people with smoking related illnesses, every 6 seconds, we know that somebody is passing away in this country. We're fortunate that we're all part of this 5% of academics over here, healthcare professionals from different sectors, but there's that 95% population out there that we're all working for, and that's our service users. So what we tend to do is to bring the best knowledge and how we can deliver healthcare services. As I said earlier, the topic is around smoking cessation. So what we did is we deliver stop smoking services as the NHS umbrella, and the disruption that we kind of did, or I kind of set the model up, was around taking the service to the people. So delivering it from either GPs and pharmacies as a traditional one, but not just that, delivering it from barbershops, delivering it from shopping centers, where people go and take the service to them. Since 2003 timeframe, we have been delivering. We're one of the largest providers. We see up to 100,000 people a year. As an organization, we have around 400 staff, and 70% of our workforce comes from the NHS. So what happens next? Right, in 2017, our chief exec was very much into, his basically background is within the IT and was on AI. Right, so we are taking service to the people. Public health budgets are slashing. We can see that they're coming down. So, but that doesn't solve the problem, does it? Because the supply is here, but the demand is here. So what happens to this gap? How do you address the gap for your wider population service? So that's when we decided to work on AI. As I think I think we should have a real good definition towards the end of the day for AI. I know it's all around artificial intelligence, but from public health perspective, I'd love to hear from the audience as well that how do we actually see AI working in public health? And maybe in tomorrow's focus group, one question would be that AI in public health, what does it really mean? Right, so that we have a clear understanding. But equally, coming back to this whole thing about delivering into larger scale population-wide services, why we do, who we do, and who do we take the service to. So local authorities are responsible for their population. We then deliver it on the ground. Universal and targeted. I think those are the two most important things. For the universal population, we went down the digital route, and for the targeted population, which is smoking in pregnancy or smoking in mental health, which was where they can still come in and visit a face-to-face service. We'll talk more about the stop smoking service and AI. By the way, the whole platform was built on the NHS guidance, right? It's based on the NCST guidelines, so it's evidence-based. I'm a diehard public health fan, so for me, it has to be evidence-based. Right, so population-wide behavior change, delivery at scale. And that's where we use the whole platform around smoking cessation. We have been supported by Microsoft. And actually the support went right at the top. The chief exec of Microsoft, Satya Nadella, when he made his visit to the UK last year in the time frame, I think it was in the month of May. And our project was selected for a showcase between 8 other projects, and he had a 5-minute catch-up with the chief exec. And when he knew about what the program is about, his words were, "This is AI for good. It's doing good for people," which I think was really good. And we're getting a lot of support from the senior team within Microsoft as well. The other thing I would like to say that we're also working with Tata Memorial Hospital in Mumbai to roll out the clinical trials to roll out for smoking and tobacco cessation in Tata Memorial. And in Wales Hospital, the Welsh government has rolled this out in all their hospitals. So how was this built? This was built on an experience of 10 years, data, knowledge, and action together. And this is a lot. So hence why when we discuss about data, we discuss about knowledge, been there, done that, from service users' perspective to academics, clinicians, everyone. And hence why I have to say, I have to thank Samir as well, because he's been part of this journey. He's witnessed us from the early stage in terms of how we have worked, what we've developed. And at this platform, I would like to share and harness and actually get experience and support from yourselves that what else can we do? How else can we take this further? We have developed something. We have other areas like other hospitals, and like, for example, as I said, Tata wants to work on it. So I would like to understand where else can we take this forward. This is introducing you to Bella, and this is the world's first robot AI e-advisor, artificial intelligence. And I will now ask Keshav, who is our AI lead, to come and talk about Bella.
Thank you, Lena. Thank you, everyone. It's been fascinating to talk to such a range of domain experts, from technical experts to healthcare professionals, to public sector people, private sector people, policymakers. And I think it's fantastic that an event like this brings together such a range of people together. So, and hopefully this will be interesting to everyone as well. The job that just one stop smoking advisor does for just one client is genuinely profound. It's transformational. Are we hearing me correctly, right? It feels like you're not. It's genuinely profound. It's transformational. It doesn't change the world, but it does change the client's world. It means they can play with their children in the park. It means they can live a fulfilling life that's potentially disease-free. And it means they can have better, higher quality moments, healthier moments with their loved ones. I think the question here, the really important, interesting question here is, how can we recreate this positive human impact on a large scale in a cost-effective manner? Now, the cost-effective manner there is important because we can, of course, all do things on a large scale if we have all the money in the world, but we know the reality of that isn't the case. And our response to that is to build Quit with Bella, who Lena mentioned is the world's first AI-powered stop smoking robo-coach. We know the best solutions must be rooted in a valid evidence base that can be trusted not only locally where you're from, but also internationally. And we're proud that Bella's been built on the NCSCT and NICE evidence guidelines. This is usually known as the international gold standard. It's what the NHS always recommends and is internationally known. And if we synthesize the literature, we can understand that these are the main points from the evidence. How do we change someone's behavior? How can we successfully drive behavior change? We know how important this is for a range of different areas to actually support and facilitate a healthier community. And so Bella does this through a natural conversation with users. A user simply talks to Bella like they would talk to anybody else on text, and they receive personalized expert support that has been built on the 200 advisors, stop smoking advisors we have at the company, and also the evidence base and input from service users. This has been blended into a well-tuned NLP engine that then I remember, I think, in the morning we spoke about how difficult it is for NLP recognition. I was speaking to quite a few technical experts here as well who've shared their challenges on that, and that's been one of the key challenging areas. And we know that's challenging in just having a conversation, but now we can imagine how challenging that is if you want to change someone's behavior. Behavior change, as many of you probably know, is a complex, nuanced, difficult activity. And now you're trying to get an AI that's trained on the evidence base, that's trained on the data we have, to be able to do that successfully. It's why that we've managed to gain support from Microsoft, important strategic support from Microsoft, technical support to develop this. Here we can see kind of in the conversation, this is me, by the way, talking to Bella a long time ago. So Bella asked me how long have I stayed smoke free for. I say about 3 days. I know that isn't much, with a little frowny face at the end. Bella's understood that. She knows how much I said I smoked. I don't smoke, but she knows how much I smoked, and has come back with even that period of time is a major achievement for regular smokers. How do you manage it? So I didn't know that actually 3 days is a long time for someone who smokes 40 a day to go smoke free, but that's an eternity for people. Do we have any smokers in the room? Actually, this is a chance to okay, one. Okay, we've got. I saw you outside. I wanted to talk to you about it, but maybe you can download Bella and provide some feedback. So I'm going to ask the question: How much do you smoke? Okay, so that's not a lot, but Bella's the expert here. I don't know why I'm not. Well, yeah. So have you gone 3 days without a cigarette? That's amazing. That's well, Bella would know how amazing that is. We'd get if you actually have a conversation with her, she'd provide you with a personalized response on that. We've also, we've talked about the experts within the app. We've talked about the experts who've helped to build this app, and they've also been used within the app. One of the key things we found from service users was, okay, fine, I can have this, natural, free-flowing, personalized expert conversation with Bella, but how do I use NRT? And I want more than just a robot giving me textual information. So people like Darush, as a national trainer on smoking cessation, is there in video form, and sometimes users say lots of things to Darush, which is interesting. Users say lots of things to Bella, which is also interesting. There's a point about NRT and medication as well. So Bella performs the Fagsum test for nicotine dependence and recommends relevant NRT, depending on what the user has already said to Bella on their preferences for medication. Bella provides a personalized recommendation for that. One of the other, I mentioned service users. We have been always driven by our service users, firstly, to develop this and to improve this. And one of the key pieces of feedback we got was, okay, it's great. I can talk to an expert, a robo coach, free flowing conversations, personalized and all that. But has Bella smoked? I'm not sure if you ever want to give up smoking, but you probably want to talk to someone who's gone through what you've gone through. If you're a technical expert in AI and you've finding technical and logical challenges, you want to talk to someone who's been through that. If you're going through a range of different challenges, you want to talk to someone who can actually help you from their own experience, and that's what we do with Bella Community. So this is a community of Bella users. Again, there's strong evidence showing that peer support successfully facilitates behaviour change, and that's one of the key reasons we've added that in there as well. So who's using this? Probably you're wondering. Lena mentioned Wales. Have we got anyone from Wales today? That's probably a ambitious question. Oh, no way. No, you're not a smoker and from Wales. Are you actually half Welsh? That's incredible. I've got my whole presentation now. I'm just mesmerised by that fact. That's amazing. But yeah, so Wales is a amazing country for there. I'm going to compliment Wales a lot now. It's being rolled out in all of Wales. And also in selected areas in the UK, doctors and nurses are prescribing Bella. We know there's a keen challenge of we want someone who wants to give up smoking, but we don't have the resources, we don't have the actual human advisors that can talk to them, that can have that personalised conversation with them to help them. And this is where Bella comes in. Professor Keir Lewis is quote is there as well. He's been as well as the kind of colleagues in a Tata hospital in India have been helping to review this and improve this, and we're focused on doing that. Trusted by a range of councils in the UK, and also now internationally. So we are from the UK, and we focus, especially rolling this out in the UK, but we've seen users globally, and I think this is very interesting because in the UK there's quite a strong support. If you want to give up smoking and you make enough noise about it, someone will come and help you. But the truth is, in many other countries, you can make lots and lots of noise about, I want to give up smoking. There's no one to help you. I know in areas, is anyone in from Russia today? Again, ambitious, that's quite. Russia, half Russian or not? I thought you were going to claim that one as well. Oh, okay. So you're half Russian now. No, it's in Russia, especially in mirrors many other countries. There's a difficulty in firstly getting the experts in who can help someone to change their behaviour, and then is there enough of them? I know in Russia they have a central telephone that one of our colleagues actually went to go train them. They rolled out a red carpet for her as soon as she came, and she kept, okay, brilliant. So how are you helping people quit smoking in Russia? There was about 6 or 7 people answering telephones. She said, "Are you trained?" No, we just give them motivational quotes and things when they call up. So there's a problem of this internationally, and Bella's a credible, trained solution to be able to provide a large scale solution to this. I believe that's the Q&A till the end. That's it from me. Thank you.
What about vodka in Russia? That may be also an interesting project. All right, thank you. So our last but not least speaker is Spiros Dimolitsas. I always have to read Greek names. Please.
Thank you. Well, first of all, thank you very much for inviting me. And being the last speaker, I'm not going to use any PowerPoint. And I'll try to be brief. I'm going to talk about a program that has been in existence probably for about 3 years. It's currently has already been implemented in the US, and it's actually been scaled up. And I'm going to talk more about the use case, and then along the way, I'll describe a little bit the technology. It is a program that is particularly well suited for data that have 3 particular characteristics. One of them is that legally they cannot be shared. The second is that de-identification destroys or at least severely impairs the analytic yield. And the third one is that the analysis is highly nonlinear. So if your data has those characteristics, what I'm going to describe, at least in the case I'm describing, it turned out to be a particularly useful approach to it. So about 4 years ago, actually I come from Georgetown University, so we're based in Washington, D.C., we hosted a conference, or a workshop actually, a White House-sponsored workshop on HIV/AIDS at the university. And we had obviously the White House, we had some public health authorities, we had some tech people, we had the CDC there. And from that conference I came, or at least a few of us came, to recognize that there was an interesting problem. People who are infected with HIV, if they're brought into care and they receive the viral or antiviral medications, the viral load can be reduced, often significantly. And when that happens, not only they're not infectious, but they're also symptom-free. So there is a great push and interest in keeping people who've been diagnosed with the virus under care, and that is what a lot of the public health authorities do in the US. But there was a problem, and the problem was that at any one time, a state who might have a database of individuals probably couldn't locate about a quarter of them to provide care. Now, part of the reason might have been that these individuals may, in some cases, have perished, in other cases, may have moved to another state. And so, what do you do with that quarter? The only way to find out is by sharing data with one another, something that's actually legally prohibited. And so we started thinking about an approach that might allow to pose a legitimate question like whether it's a particular individual that had, in fact, to compare data from multiple states often and provide an answer to it. I should add that while states are legally prohibited from sharing the databases with one another, if they can confirm that an individual in one state's database is the same as in another state database, then they can exchange the clinical records for that individual. And so the question is legitimate. Is a particular individual that is in one's database the same or different than an individual in another state? And if so, a process can begin for exchanging those records. Now, that used to happen by hand. In fact, in many states, still happens by hand. And for that reason, the statistics that are reported about HIV, at least in the District of Columbia, is where we work, are typically 3 years in arrears. So, what is reported today was really true 3 years ago. So we developed a program that initially looked at 3 states, the state of Maryland, Virginia, and the District of Columbia, strictly speaking not a state, but part of a metro area, which collectively, I believe, had about 300 cases. And we did a pilot study. It was actually very interesting. If I had a picture to show you, you would probably see a little hotel safe, and in the hotel safe was a really mini-Mac, but that was big enough actually to accommodate the case, and we did the comparison in about 10 minutes or 10 hours, I forget. In about 10 hours, we were able to analyze the data from these 3 different states and give them a report back about individuals that actually occurred in more than one state. We then expanded the program, I think it was 2 years ago, to the Eastern Seaboard. We did about 9 states, all the way from New York down to Florida. To our surprise, we discovered that the same ratio probably persisted even when we did 10 states. About a quarter to a third of the records were actually not correct. They had some problems with it. Maybe the name was incorrectly spelled and they couldn't find the person. The social security number had digits transposed. There was no address. All kinds of problems with the records, but about a third of them fell into the same category. And it was no longer just neighboring states. You would find people from New York down in Florida and people from Georgia back in New Jersey. So there was, fluidity among the population that maybe is characteristic of the U.S. population moving around. But nonetheless, it provided justification for why you couldn't just look at the problem regionally, you had to look at it more widely. And a year ago, the Center for Disease Control gave us actually a contract to deploy a nationwide system, which we have started implementing as we speak. We did our first nationwide run. We do a run to compare these records every 3 months. We did the first one in November. We had, I believe, 18 states at this particular time, and we're preparing for another one at a time that will be approximately 3 months from the previous date. We expect to have about 24 states or 25, and we hope to probably go to about, I would say, 30 or 35 jurisdictions, which include some major metropolitan areas like Los Angeles County and San Francisco County, which currently they're not in a database. So how does the whole thing work? It was actually no single brilliant invention. It was really the smart integration of about 100 different novel ideas that really share 3 attributes. Number 1, a governance. Number 2, physical. Number 3, cyber. So there were really 3 things that were brought together. And the innovations really came from 2 communities, both of them actually in the national security sector. One was the cyber community, how to protect or attack cyber assets. We had some of the best expertise that serendipitously became available to us at Georgetown. And the second was from the defense industry, people who worried about the security of our weapons. How do you stop a weapon from being fired when you don't want it to be fired? And if it gets fired, how do you stop it from coming back at you? So we had people who were experts in those 2 communities, and together they brought all these innovations to create, I will call it a trusted system, although it has elements from multiple of the other things that we saw, to create effectively an environment where you could demonstrate with a high confidence that it would be impenetrable to anybody who really did not have legitimate access to see the results of the analysis. The way it works, roughly, and I can answer more questions in detail later on, is you create a computing platform, effectively. The computing platform was designed without any persistent memory, so there was no way you can store data on that platform. You can only temporarily host it and analyze it. That platform is in an enclosure, in a physical enclosure, actually multiple physical enclosures, but the innermost enclosure is cyber-locked with the platform. So if you open the door to get to the platform, power goes down and you lose all your data. The way it works is you preload your analysis. The analytics are written in a specific language that can be mathematically proven. It's a verifiable language. It's typically, in our particular case, is the Ada language, which is not very commonly used, but is used for avionics and weapon systems. You preload the analysis, you close the box, you close the enclosure, data comes in encrypted. When it's ready to be analyzed, it gets decrypted in dynamic memory, gets analyzed and immediately wiped out. Pretty much the entire operating system is disabled. The only functions that are left in the operating systems are those that are needed to create a library, a directory for each data stream coming into the device, and to output pre-authorized individuals the result. If you want to open the enclosure, actually no single individual can do it because there are multiple keys, just like we do with our weapon system. So Georgetown has one key, but there are another two keys. Typically we have three, one from each health jurisdiction. Two health jurisdictions basically have to be present. And the same thing when you set up your computer, the password has got multiple parts. No single individual has got a single password, the whole password. All three individuals need to be there in that particular case to type in the password, or the part of the password, and then you get access to the system to actually load it. There are many other tricks, I guess. As I said, there are probably about 100 different ways we combine to create that secure environment. And as I mentioned, it has been now in operation for about 2 years. Now we're scaling it up to a national system. I think that's probably all I'm going to share about it. I'll be happy to answer questions, but I thought I'd better be brief and you do it without PowerPoint. Thank you. And I got us back on time.
So, except from those from Ada, about the language Ada, are there any questions?
This is Muhammad Noor from WHO. For the robot of that dialogue that you have in England, is it multilingual? I mean, I see that you said that it's there in several countries globally. Is it working in English only, or it's multilingual?
Yeah, thanks for that question. So, no, not yet. No, right now it's only working in English, which is also why it's fascinating to see such an international audience actually take up and use it. See, English is a language spoken everywhere, but we are keen on making this multilingual. But that has its own challenges because not only do we need to translate what Bella needs to say in order to change someone's behaviour, we need to make sure that's specific to each kind of dialect and how different people understand different words. It's difficult just to kind of put what Microsoft like to think is easy to put translate on it is actually difficult to in order to actually facilitate behaviour change in those languages. We need to have quite precise details to understand how language impacts on those areas. So we are looking to do that, something that will happen shortly.
I have another question, if possible, for...
Sorry, can I just add to that? It is in pipeline, as Cash mentioned, right? The technical aspects is what we need to look into. I think the most important thing around behavior change is also about being culturally sensitive. So having that in terms of whichever language you translate to, you have to be very culturally sensitive towards those communities and then deliver it.
May I ask another question?
Please go ahead. That's the neighboring room that's making that noise, I think.
Dr. Spiros, regarding the method that is invented there, is it shareable for others to learn about it, or it's something that is very confidential for the community that is working on military and working on this kind of security?
Is it on? No, it is not confidential in sort of the security sense. It is really leveraging innovation that happen in those communities, but it is shareable. Certainly, you know, we try not to make every detail public, because for the simple reason you don't want to create a target, as I call it. If people know, for example, let me backtrack, when we actually do a run, we don't advertise that, because we don't know that short moment of time where data might be persisting and encrypted in the device while they've been processed. But to answer your question is no, I think this is generally publicly available information. It's just the very innovative integration of all those features that make it unique. I should have said when we did our first pilot, and even now, something that surprises people is that we have received exemptions from both the IRB. So even though we typically take attest to the review boards, because no human sees it, we get exceptions from the IRB. We have a HIPAA exception, so we don't need to comply with the HIPAA requirements. And most recently, we got a FISMA exemption as well, so we don't need to comply with the Federal Information System Management Act requirements, because of the confidence in the technology that the human is so isolated from the ability to look at the data and do anything with the data that doesn't require any of those assurances.
Another question regarding this point. Is it now moving forward for the quick coming out of the statistics? You said that the range is 3 years to benefit from the statistics previously because of this kind of lack of sharing of information. Now, after implementing this, is it impacting the speed of coming out of the results or not yet?
Yeah, we're already providing results. The most basic information that comes out is we will transmit to one state that the individual in your database by this number is the same individual as an individual in another state. That gives them the legal authority to call the other state and ask to change records. But now jurisdictions are asking us to do more than that. So we're doing additional work like, let's correct the residential address that may be in error. Let's create more complete clinical records, since there is a clinical record in 2 different states, or maybe sometimes more than that. Let's pull it all into the state that the individual is currently requiring. So we're doing some statistics, and that is typically what we see at Georgetown, just the average statistics. We actually should have said that Georgetown never actually sees the output of the analysis. The analysis goes directly to the customers that are providing the data. But it is beginning to provide additional information, including molecular data. And now we're beginning to look also at other comorbidity, like sexually transmitted infections.
So there's the rationale behind this very secure system that you are having is that people otherwise wouldn't give their data if it wasn't that secure. Is that the rationale why you would go this extra?
That is correct. I could have said that the first pilot we did took about 24 months. About 22 of those 24 months was trying to explain to those who were hoping they would contribute the data what the technology actually did and why they should trust the device to actually contribute the data. Okay. The next 2 months, I guess maybe a month and a half, was actually writing the analytic and verifying its mathematical correctness. And then the actual work took, I don't know, 2 days.
Well, that reminds me to the focus group. I think the actual benchmarking will take a very small amount of time and the rest will be all the work. So any more questions? Please.
So this is sort of a back and forth question for Shashank and Spiros. I was fascinated when you talked about operational trust. Now you can get all the computational stuff cleared up, and people still might not be ready for it. And I was sort of wondering, because it seems like what Spiros was saying is, hey, we worked out a system where we were able to deal with a lot of those operational trust issues by just so removing humans from it that it didn't matter. So I'd sort of be interested to hear what the two of you thought of your sort of related comments. And then for you, Shashank, I was also interested looking at the focus group and the issue of operational trust. Have you in your work been able to identify certain factors or characteristics that are particularly helpful for ensuring operational trust or particularly likely to undermine operational trust? And if so, what would you recommend that the focus group focus on in that regard based on what you know about it and its goals?
Yeah, I can take it first. Yeah, we broke down trust into two things. Number one is, do you trust that the individuals who are providing the device, the framework, the platform, whatever you want to call it, are competent enough to actually get it done right? So that is a question of competence. And we have paid very special attention in our particular case, in our latest system. We have actually partnered with another institution that can provide sort of as high confidence as you can in the United States about their ability to implement a cyber-physical system very correctly. And the second part of trust is, do you trust that person to actually do what they said they were going to do? So that's a question of almost personal trust. And to solve this a little bit, that's why we have what we call the two-person rule. So a single person cannot actually do anything on their own. They need to have somebody additionally working next to them, whether it's, to code the multiple password or to have multiple locks. And the third level of trust, in our particular case, we're moving towards an environment where the individuals are actually cleared. So they're not just any individual, but they've gone through some level of vetting before they can actually even get close to the device. So, but there are those two fundamentally different trusts. Do you trust the individual, and are you sure that the individual is competent enough to do what they said they were going to do?
Thank you. I actually see a third layer of trust on top. So I guess if you're working in US, you might have gone to a NSA, one of these agencies for verification. When we look at the work from UK, they've followed guidelines from NHS, and that's a sort of a competent authority which is saying that whatever this work is being done, there's a third-party audit view to that. So, but when you take that in an international context, and especially when we as ICC work with different UN agencies, it takes a different dimension. And I guess it's the UN brand where that acts as the trust anchor. So if the system was to run in US and a third country had to supply data to them, essentially what you're saying is that, don't worry, NSA has certified this, so this is all good. Now, would that third country take that NSA certification as a positive or a negative issue is a totally different element. And thus the perception also plays a role in that. So in the kind of systems we deal with, in the kind of information we deal with, for example, International Court of Justice, World Trade Organization in their arbitration process, while it is a question of individual trust, are the people who are working on it, can they be trusted? It is also an element of the institution being trusted. So that is what I think the value, the UN ecosystem brings to the table. Now, as to your specific question about the working group, I'll be very honest. I don't have all the details to sort of, give feedback on that. To sort of, give any comment. I honestly don't have much information to reflect on. Does that help?
Thank you. I mean, to some degree, the focus group works under the assumption that the data are given, already available. I don't think we are probably going to get into the business of collecting data ourselves. We don't have that capacity. That's the first thing. The second one is we have already drafted a guideline for data acceptance, and one aspect there is anonymization. So we for sure not look at data that can be matched to a person. We just don't want to see any of that in our area. So that's why we would think that the UN label is a trustworthy element by itself, and maybe that's why this might be the right avenue to go forward. Now, the question is, so you have created Spiros, you have created a system that technically conveys some degree of trust. I know that at the University of Geneva, there's also a project running for a data space, a patient data space. I mean, to some degree, all these topics are around patient data spaces and patients giving away the data to the digital world. And there are lots of projects in Germany. There's one, and I think in other countries there are lots of them. So, is there any way that these things can come together? And one more question to you: do you have an ADA program that spits out the data anonymized so we can use them in our work?
Well, the answer to the last question is no. We at Georgetown do not control or even see the output. I think that is directly provided to those who are contributing data. Actually, we don't call it data sharing, we call it data contribution. I'm not personally very familiar with what's happening in the University of Geneva, but we're very interested. But just to add, I think, to your point, which I think was a very good one, even within the United Nations, just like we do at Georgetown, I think having the technology available for verification and validation by a third party is very important, and we do that as well. I didn't mention it, but if one of our customers wants to bring somebody, we invite them to the design review so they can do independent design reviews of the code, but also anytime it's available for inspection.
Okay. Are there any more questions? Yes, there's one.
My name is Max Marz. I'm working for the Federal Network Agency in Germany, and once worked together with the OPCW, which is part of the United Nations for the chemical weapons, and they collect the data too, and we collected from Germany data for the OPCW, and it's possible that in the world, hospitals can collect data, send them to an international organization like the OPCW, but it should be founded. That's my intention.
Okay.
So I can just sort of react to it. Obviously, it depends on the number of organizations, but within the UN ecosystems, there are a number of operational organizations. IAEA is another example, which does similar work. I mentioned WTO, they look at arbitration process. So there are examples of operational organizations which collect data and sort of act on it. And yes, technical security or information security does play a large part in that as well.
Very good. Any more comments or questions? If not, well, let's thank the speakers again. Thank you for coming.